Pulsatile Minimally Invasive Perfusion Obstacles and Advantages by Hoenicka from the Department of Cardiothoracic Surgery from Germany.
Okay, good morning, everyone. Dear audience, dear chairpersons. First of all, thanks for inviting me, for giving me the opportunity to present some data here. I will share my presentation. Okay. First, disclosure, we have used a pump in these experiments, in some of these experiments, which was a loaner from a company, which was provided for the duration of these experiments free of charge. First to the background. Everybody thinks that pulsatile perfusion can improve organ perfusion during cardiopulmonary bypass, especially by improving brain perfusion and kidney perfusion, although the clinical evidence is somewhat contradictory. We also conducted a pulsatility trial in Ulm at our own medical center. We compared cabbage patients with MiECC pulsatile versus non-pulsatile. We saw improved urinary excretion by pulsation, and we also saw transient TPA elevation, but it did not alter the fibrinolytic balance overall. So this is also not very impressive, and this led to the hypothesis that the pulsatile energy which actually arrives in the patient might be too low. And therefore we went back to mock circulation to investigate this issue. Let me first start with a little bit of background, should not be too technical. We can calculate the energy provided by perfusion from terms including the flow and the pressure. If you look at this EEP formula, if the flow does not alter, these flow terms cancel out, and EEP is simply equivalent to the pressure. However, if the flow alternates by pulsation, you gain some energy, and this is calculated as the surplus hemodynamic energy, or SHE, in the lower formula. And this is normally normalized to the mean arterial pressure, so you will see the results as % of MAP in a couple of slides. And our idea was basically to optimize the extracorporeal circuit to maximize SHE, and you can do that in the mock circulation without harming any patients. We used different types of pumps, default roller pumps. We used these DP3 diagonal pumps as non-occlusive pumps, and we also used a prototype pump, positive displacement pump. In most experiments, regular kit tubing was used. We used dextran solution as a blood replacement. There was an oxygenator present with a heater cooler unit at 37 degrees. We used aortic and femoral cannulas as needed. The peripheral resistance of the aortic model was adjustable to give physiological flow and pressure readings in the side vessels. And we used lots of flow and pressure probes to see what's happening. The aortic model was a compliant model, very similar in its elastic properties to a native aorta. First of all, we checked the tubing, the influence of tubing on SHE transfer. There was a paper by Wong et al. From 2017 that claimed that high compliance silicone tubing caused a higher transfer of energy into the patient. We simply could not believe that, and we were actually able to demonstrate that this was misinterpretation in the original paper, because they used a non-compliant pseudo patient in their results. But for us, the most interesting result was not that the kit tubing was in fact better as we expected, but the dependence on the flow. As you can see, the SHE has a maximum around 1.5 liters per min, which is okay for pediatric surgery, for example. but adult patients need a lot higher flow, and SHE drops again at these high flow rates. Next, we checked the influence of oxygenators and of aortic cannulas. You can see on the upper left, the pressure gradients differ by a factor of 2 between different makes and models. Of course, it's better to choose an oxygenator with a low pressure gradient because this relieves the pump from unnecessary work. And on the right-hand side, you see the SHE. It's very similar, except for this one oxygenator with an exceptional high pressure gradient. But we choose actually the blue one in these images for further results. The influence of the aortic cannula basically depends on the size. 15 French gave somewhat limited SHE transfer, but 21 or 23 was essentially as identical. So we concluded the cannula has to be big enough, but not huge. Next, we optimized the console settings, that is what influences the DP3 pumps. And we started from the empirical settings from our perfusionists. They used a frequency of 50 BPM, a systolic percentage 50%, and a speed gain of 2,300 during pulsation. And this gives the red curves in the images on the right. We made a sort of a grid optimization and ended up with lower frequency at 40 BPM, 35% systolic percentage, and the maximum possible speed gain. And you can see the blue curves, they're a lot higher, although the main difference is again at 1.5 liters per minute. If you look at the highest flow rates, there is still something to gain, but not that impressive. On the right-hand side, you see the pulse amplitude, the pulse pressure. And as you can see, a high pulse pressure does not necessarily translate to a high SHE. These are really different entities. Next, we ran a couple of experiments with dual DP3 pumps. The idea was to run 2 pumps at half speed rather than having one pump max out at maximum speed at the highest flow rates. And we investigated different combinations. For example, pulsatile pump and another non-pulsatile pump, or both pumps pulsatile synchronized. And we also investigated whether it makes a difference to run both pumps through the oxygenator or have one pump bypass the oxygenator. The results was essentially best is to run both pumps at the same speed, both pulsating, and have only one running through the oxygenator. And this gave the best readings, although the improvements over a single DP3 setup is not very impressive. So this was interesting, but did actually not provide a solution to improve the SHE at high flow rates. Next, we ran a couple of experiments with this pump prototype, which was provided by the Triphasic company from Australia. This is a positive displacement pump, entirely different principle compared to these DP3 pumps. And we ran a complete characterization of this pump, but I will show only one set of experiments to show you the principle. The stroke volume on the x-axis is comparable to the RPM setting of a DP3 pump. The higher the setting is, the more the flow is. And this prototype actually achieved maximum flows of 2.5 liters and a limited pressure, as you can see, but then again, it was a prototype. But if you look at the right-hand side, the SHE was in some settings above 50%, and at the highest flow rate, you could still achieve more than 30% of SHE, which is far higher than any DP3 could ever achieve. So this was very promising. Finally, we had a look at femoral cannulas. They're not only interesting in MiECC, but of course also when using a VA ECMO, for example. And we were basically interested in looking at cannula types which provide an additional distal perfusion. So they have additional holes pointing backwards to perfuse the cannulated leg. And main focus was to see whether they actually provide appropriate distal perfusion. And as you can see from these images, we compared these with regular femoral cannulas and regular cannulas supplemented with an additional distal perfusion cannula. And I would skip the part of the cannulas themselves and focus on the effect of pulsation. We were actually thinking that pulsation might improve the distal perfusion by simply adding a pulse to the cannula, but in most cases pulsation was actually worse, so it did not help distal perfusion in these experiments. A couple of cannula, the Rivas, and with or without an additional cannula were actually best and were not affected by pulsation. So let me summarize this real quick. The kit tubing is perfectly fine, so you can use whatever you have. The pressure drop of the oxygenators is most likely more important than any effect on SHE. You might wish to review the diagonal pump settings because there's a lot to gain, at least at lower flow rates. And you might wish to keep an eye on the progress with these positive displacement pumps, as they provided an excellent opportunity to improve the SHE. I would like to thank all the students that were involved in these experiments, and thank you for your attention.
Thank you so much for this interesting presentation. Very, very, very interesting. There are questions from the audience. Okay, from the panel, from our panel. Okay.
Thanks again for a very nice talk. Do you think clinically using pulsatile flow, are there any risks or drawbacks to potentially using this clinically? I think of things like shear stress or potential cavitation as you have the flow rapidly increasing and decreasing.
Well, you have to keep that in mind, that you can produce cavitation if you exaggerate the pulse pressure, for example. But otherwise, I think the risks are limited, given that the heart itself is a pulsatile pump by design. So if you keep it within these limits, I think you should be pretty much safe.
Thank you.
I have one question for you. Do you see in your experience that the use of pulsatile flow, in particular in high level of hematocrits, increase the plasma-free hemoglobin in your experience?
I think we cannot answer this question from our perfusion model, because we simply use a different type of medium, and we cannot analyze these effects as much as you could analyze them in a patient.
Okay, thank you. Thank you so much.
Thank you.
If we not have other question, we introduce other